Lyme disease is incredibly common, yet notoriously complex to track. Today, we're breaking down its entire clinical progression and neurological impact, completely unpacking the timeline so you have a crystal clear understanding of exactly how this disease operates from day zero all the way to chronic illness. We're going to go through every specific finding, every percentage, and every diagnostic rule point by point. The goal of this explainer is to completely clear up these concepts for you so you won't even need to crack open a textbook afterward. Let's dive right in.
Here is our roadmap. We'll be following the clinical arc across 5 distinct sections: the basics of the disease, stages 1, 2, and 3, and then wrapping up with exactly how clinicians test for it.
Section 1. The basics of the pathogen and its vector.
So, Lyme disease is a massive, complex, multi-system illness. In North America, it's caused by a highly specific spirochete bacteria, known as Borrelia burgdorferi. Now, this bacteria gets transmitted to humans through the bite of the Ixodes tick, specifically Ixodes scapularis or pacificus. And here's a highly testable, often surprising detail you absolutely need to remember. The American dog tick is actually not involved in transmitting Lyme disease at all. It's a classic trap. First recognized back in 1975 in Lyme, Connecticut, this has absolutely exploded to become the single most common arthropod-borne infection in the United States.
Moving on to Section 2, Stage 1, Early Localized Disease.
While we break this illness into stages to keep things clear, keep in mind they can sometimes overlap in the real world. In Stage 1, the absolute hallmark physical sign is erythema chronica migrans, or ECM. You probably know this is the classic bullseye rash. It's an expanding, macular rash, meaning it's a flat, distinct, discolored area featuring bright red borders with a central clearing and a firm, raised center that we call induration. It usually pops up about 3 to 30 days after the tick bite, most commonly in the thigh, the inguinal region, or the axilla, and we see it in about 60 to 75% of patients. Fortunately, this rash usually fades completely without any scarring in about 3 to 4 weeks. And while ECM is the famous one, patients might also show up with diffuse erythema or urticaria, which are just hives.
Right alongside that rash, patients are typically getting hit with intense flu-like systemic signs within days to weeks of the initial bite. We're talking fevers, chills, and malaise, which quickly progresses into this deep, heavy fatigue, lethargy, backaches, and headaches. They often suffer from arthralgia and myalgia, joint and muscle pain. You might also find regional or generalized lymphadenopathy, so swollen lymph nodes. Interestingly enough, about 13% of cases actually present with a malar rash right on the face. And here is a vital clinical point that is so often overlooked. Within just 30 days of the tick bite, those Borrelia spirochetes can already be demonstrated in a cellular spinal fluid. The spread happens incredibly fast. But what happens if this early localized disease goes completely untreated?
That brings us to Section 3, Stage 2, Early Disseminated Disease.
In Stage 2, we start seeing signs of much more serious organ involvement. Let's contrast 2 key areas here. Cardiac manifestations happen in about 8% of patients. These primarily present as conduction defects, usually an AV block that's generally brief and mild, as well as myopericarditis. On the flip side, ocular findings are extremely rare, but when they do occur, they are severe. We're talking conditions like panophthalmitis, which is the severe inflammation of the entire eye, or ischemic optic atrophy, where poor blood flow literally damages the optic nerve, along with interstitial keratitis.
And this leads us straight into the crucial neurological triad of Stage 2, affecting roughly 10 to 15% of patients. This triad consists of cranial neuritis, meningitis, and radiculopathy. I really want to zero in on cranial neuritis for a second because it frequently mimics Bell's palsy. In fact, Lyme disease is the single most common cause of bilateral Bell's palsy, facial diplegia, in endemic areas. Seriously, if you ever see bilateral facial nerve palsy in a clinic, Lyme disease needs to instantly shoot to the absolute top of your differential diagnosis list.
The truly vital concept to grasp here is that these neurological findings don't just stay put in one place. They are frequently migratory, and roughly 60% of patients actually experience multiple neurological findings simultaneously. Other possible neuroinvolvements include encephalitis, myelitis, and peripheral neuritis. There's also a highly specific regional variation you should keep in your back pocket. Over in Europe, the most common manifestation is Banwarth syndrome. This primarily hits the peripheral nervous system and involves chronic lymphocytic meningitis, peripheral neuropathy, and radiculopathy. Luckily, even without intervention, these Stage 2 neurological symptoms do usually resolve gradually over time.
Let's look at Section 4, Stage 3, Late Disease.
By Stage 3, arthritis and chronic neurologic syndromes really take center stage, and this is happening months or even years after the initial infection. Now, simple arthralgias, just general joint aches, were common back in stage 1, but true, full-blown arthritis takes much longer to develop. This true arthritis eventually strikes about 60% of untreated cases. When we break down which joints are targeted, it's overwhelmingly the knee, at a staggering 89%. That's followed by the hip at 9%, the shoulder at 9%, the ankle at 7%, and the elbow at just 2%.
But beyond the arthritis, stage 3 is heavily characterized by chronic neurologic syndromes that can absolutely devastate a patient's quality of life. The list includes encephalopathy, encephalomyelitis, and peripheral neuropathy. The tricky thing here is that all of these are chronic, and their manifestations can be deceptively subtle at first. More overt, severe, late-stage neuroinvolvement includes ataxia, which is that profound loss of coordination and balance, as well as dementia, severe sleep disorders, and incredibly complex neuropsychiatric diseases, all paired with intense fatigue syndromes.
Which brings us to Section 5, Diagnostic Criteria and Serology.
Okay, so now that we've mapped out the entire clinical progression, how do clinicians actually test for this? It's not easy. There is no single test indicative of an active infection, and the Borrelia spirochete is notoriously difficult to actually culture from humans. Diagnosis is pretty straightforward if you have a history of travel to an endemic area, a known tick bite, and that classic ECM bullseye rash, but for everything else, we have to rely on very precise CDC criteria. Notice the strict divide here based on geography. In an endemic area, having the rash alone is enough, or an antibody titer of 1 to 256 or greater, plus involvement of at least one organ system, whether that's musculoskeletal, neurologic, or cardiac. But if you're in a non-endemic area, the rules get stricter. That ECM rash must be paired with either that high antibody titer or involvement of 2 or more organ systems. Now, testing too early is a massive clinical pitfall. You absolutely must follow this exact serology timeline. Once the infection occurs, it takes a full 7 to 10 days for the body to even develop initial antibodies. Then it takes about 2 to 3 weeks before those antibodies can actually be reliably detected in untreated patients. And remember, giving early antibiotics can suppress this immune response. So if that first serum test comes back negative, but your clinical suspicion of Lyme is still screaming high, you should repeat the test in 4 to 6 weeks. Seeing a seroconversion from negative to positive over that specific window strongly supports your diagnosis.
When it comes down to the actual testing mechanics, the enzyme-linked immunosorbent assay, or ELISA, is our standard go-to method. It detects both IgM and IgG antibodies. IgM elevates acutely right away, while IgG rises much more gradually, becoming elevated in almost all patients at that 4 to 6 week mark. Interestingly, those IgG levels are usually the absolute highest in patients who have gone on to develop arthritis. But because the standard ELISA isn't perfect, we always bring in the Western blot as the rigorous confirmatory test to weed out false positive ELISA results. It is much more sensitive and specific, though you should note that results can occasionally vary slightly between different labs.
Diagnoses can be incredibly tricky here. False positives on these serology tests can absolutely happen if the patient happens to have other borrelial or treponemal infections, most notably syphilis. Thankfully, running a standard VDRL syphilis test will cleanly differentiate between the two. But what about PCR testing? Well, PCR amplifies the bacterial DNA, making it a highly sensitive test. However, you really have to be careful with it because it can yield significant false positives. A PCR test can come back blazing positive even if the DNA it's detecting is solely from dead, completely inactive organisms.
Finally, if the nervous system is heavily involved, an analysis of the cerebral spinal fluid or CSF becomes totally necessary. In late-stage disease with neurologic involvement, the CSF is going to reveal some highly specific markers. You'll see an elevated CSF IgG antibody titer specifically to B-Burgdorferi. The overall fluid findings are usually going to be compatible with aseptic meningitis. Plus, you might find the presence of oligoclonal bands, which are essentially proteins that indicate central nervous system inflammation, and an increased ratio of IgG to albumin.
Wow, so we've covered a tremendous amount of ground today, right from that very first tick bite all the way to the complex neurological and joint damage that can linger for literally years. I want to leave you with this absolute golden rule of treatment. Antibiotic therapy is significantly more effective early in the illness. Catching and treating Lyme early isn't just an option. It is an absolute necessity if you want to prevent irreversible, life-altering damage like dementia and widespread arthritis. So the very next time you hear about a tick bite, remember that the clock is ticking. Are you ready to spot the signs before stage 2 sets in? Thanks for joining me on this explainer.